afternoon, Australia, and good morning, Uganda. I'm Zooming to you today from Gadigal country, and I acknowledge ownership of this land. I would like to pay my respects to elders past and present and emerging. My name is Julie Rosenberg and I'm the Executive Officer at AIDN, the Australian International Development Network. AIDN has a very straightforward mandate or mission, and that is to facilitate more and better international aid from Australia. One of the ways that we go about delivering this mission is by building awareness of issues and events around the world. Today, we are going to be having a look at the heartbreaking crisis that is engulfing Uganda. Today, we've got an amazing panel of 5 Ugandan leaders who have all generously given up their precious time because they are so busy to share with us in Australia and bring us up to speed. One of the women on the panel, I'm proud to say, is my colleague and friend, Alison Masu. I wanted to welcome you all today and to thank you so much for your time. AIDN is also really lucky in that it has an amazing group network of friends. One is Anuba Rawat, and I want to thank her for actually helping us pull this session together. And the second is the amazing Eve Amala. Eve will facilitate our session today. Eve is an amazing young leader herself, Ugandan, an international development sector expert. She has worked for the last 12 years in a wide-ranging, varied roles. She's been with Siegel and Gould Foundations, PFE, Planet Wheeler, African Visionary Fund, FREO2, and Fundibot. It is my pleasure to know and work with her, to introduce her now, and to actually hand over running of this session to her. Thank you, Eve.
Thank you, Julie. That's a very humbling introduction. A very warm welcome again to everyone. Thank you for joining us. So most of our speakers today are in Uganda, based in Uganda, and sometimes we have internet issues there. So I hope you understand if we have any technical glitches, but I'm confident that it's going to be a perfect call. So today we're talking about the COVID-19 situation in Uganda. As many of you have heard, or maybe not, COVID cases are rising dramatically due to a combination of issues. There is different virus variants, and it's a very overburdened healthcare system, low vaccine access, among other issues that are engulfing Uganda. So this has led to very high hospitalization and death rates for COVID-19 patients among all age groups. As a result, the country has gone into a 42-day lockdown. And as we know, economic activity has been severely disrupted. The education system has been disrupted, and there are many, many other unintended negative consequences as a result. So today we're going to hear from different speakers about the situation on ground, how we can support them, and we're also going to hear from partners here in Australia about what they're doing to help. So we will have a Q&A session at the end. And so please feel free to type your questions in the chat or Q&A tabs. Thank you. So without further ado, let's hear from our first speakers, and that's Lorraine Kabunga and Yewande Kamuntu, who work with Clinton Health Access Initiative in Uganda. Yeah, there we go. So Lorraine will take us through sorry, Lorraine. So yeah, Lorraine leads the Early Childhood Survival Cluster, which houses 3 programs, including medical oxygen. And Yewande is the program manager of CHAI's Oxygen Expansion Program in Uganda. So both of them work very closely with the Ministry of Health and have been engaged in the national response around medical oxygen. And so Lorraine and Yewande, we're hearing a lot that hospitals in Uganda are overwhelmed, oxygen has run out, people are dying because of a lack of oxygen. Can you set the scene on exactly what is happening, the situation around medical oxygen shortages, and where the most help is needed? Thank you.
Thanks, Evelyn. So maybe just a bit of background. We're in The second wave, some would argue it's probably our third wave. And what's happening right now is we have a more aggressive wave with a shorter doubling time, which basically means that the rate of doubling of cases is, or at least the number of days it takes for cases to double, is much shorter than before. Earlier on in May, we were around 60 days, 68 days. And as I speak, we're probably at 20 days, which means that we have a more aggressive strain and also a more aggressive wave before us. And what I'm sharing right now, as of 18th June, we had close to 70,000 cases. We have a map there that's giving you a sense of the geographical spots where most of those cases are being reported in the northern region, a bit of the central region. We have reported about close to 600 deaths. Our country launched vaccination early in March, and while we've seen uptake, we have a very small proportion that has received the second dose, so basically fully vaccinated, as shown. And then, of course, our case management, as shown in the slide, we're close to, or I assume right now we're probably over the 1,000 admission rate. So broadly speaking, there are strategies in place, not to be an alarmist or anything. And as you mentioned, one of them obviously is that we have a national lockdown in place, and that's basically to prevent or minimize community spread, and also just to make sure that those who are critically ill, at least there's time for the system to be able to get them the access to oxygen and all these other sort of emergency services. But in addition to that, the country has a resurgency plan. And we've listed the critical pillars within those, within that plan. And we also have partners on ground who are working tirelessly to support the government with these efforts. So I'm going to ask my colleague, Yewande Kamuntu, to speak a little bit more about the oxygen landscape and what we've been doing, and sort of going to then what the critical needs are. Over to you, Yewande.
Thank you so much, Lorraine, and good afternoon, good evening, good morning to you all. So just in terms of the landscape, so we have currently COVID treatment units across the country. In the public health sector, they are based at the regional referral hospitals and the national referral hospitals. And then we also have a few private facilities managing COVID patients. So across all the regional referral hospitals, they have an on-site oxygen plant. However, this is a small capacity plant, which is usually producing approximately 15 cylinders per day. And these plants are not directly piped to the ward. So we fill cylinders from these plants, and then these cylinders are transferred to the patient bedside. And of course, this is logistically challenging, and it also presents safety challenges, particularly in smaller wards where you have many cylinders dotted around the place. It's also an infection risk as we're moving cylinders in and out of wards, especially the COVID treatment units. So currently, as Lorraine has mentioned, we have a high volume of patients admitted with severe and critical COVID-19 disease, which is different to the picture we saw in the first wave, where we had many asymptomatic and mild cases. And just to give you a picture, a single patient on high flow oxygen can consume 6 cylinders per day. So just 3 patients on high flow oxygen would really consume the total volume of oxygen produced by the plant ordinarily. But in response to the current surge, the regional referral hospital oxygen plants are really running non-stop. And so they're able to produce about 40 to 50 cylinders per day. But because we're running these 24 hours, this is resulting in frequent plant breakdowns, which is obviously causing interruptions in the oxygen supply. So in terms of the oxygen demand, where we're at right now, it currently exceeds the total oxygen production capacity that we have in the public health facilities. And we've only reached approximately 25% bed capacity for COVID cases. And we've already exceeded the production capacity in the public sector. So in the short term, we're relying on private industrial oxygen suppliers to refill cylinders. And we're also working with the National Drug Authority to conduct assessments such that we can have those industrial oxygen suppliers certified to produce medical oxygen. However, we currently have a severe shortage of cylinders to execute this short-term solution. And of course, the logistics involved in transporting large quantities of cylinders across the country on a daily basis is very challenging. Although if we had sufficient number of cylinders, the refill frequency could be reduced to a more manageable schedule. Another challenge we have is that there's a lot of focus on COVID right now. And of course, there are other patients that would ordinarily need oxygen, including children and newborns who need oxygen for severe pneumonia, malaria, sepsis, surgery, birth asphyxia, etc. And these have really been forgotten as oxygen is being redirected to manage COVID-19 patients. So if we had some more concentrators, we would be able to at least manage these non-COVID patients who are requiring lower oxygen flows. And then we can reserve the cylinders for the COVID patients who require higher oxygen flow. So what we've done, working alongside the Ministry of Health as part of the Oxygen Task Force, we have, of course, engaged these private oxygen suppliers to help with the supply in the short term. We've also put in a couple of applications to Global Fund for the COVID-19 response mechanism. And this was successful last year, and we were able to get cylinders, concentrators, delivery devices such as nasal prongs and non-rebreather masks, as well as a few other items required to deliver oxygen. However, unfortunately, we haven't yet received most of these items. We've received some concentrators, and we're expecting deliveries of the rest as soon as possible to help with this current surge. In the application for this year for Global Fund, we also included some plans now to build the capacity. Because as I mentioned already, we've already exceeded the capacity in the public sector, and we really need to plan for the future. So in the medium term, we would really want larger oxygen plants based at each of these regional referral hospitals with direct piping to the wards so that we can eliminate the need for moving around large quantities of cylinders in the longer term. And these plants could serve both the regional referral hospitals and the lower level health facilities in the catchment area in line with our national oxygen scale-up strategy. However, the most immediate need for this current surge is cylinders and accessories such as the regulators and flow meters, as well as the delivery devices, particularly the non-rebreather masks. And as I mentioned before, the concentrators would also come in useful. So I'll hand over to Lorraine just to conclude on this piece. Thank you.
Thanks, Yewande. And so, just to tie everything together, Yewande has spoken about the critical needs within the oxygen space. But we also know that, HR, diagnostics and testing, vaccination, emergency transportation, infection prevention and control, those areas are showing up as, critical needs even within this COVID resurgence. So the plea, I guess, is this is the ask. How do we get, additional support for HR, especially that are working within the ICUs? How do we get more support to do more testing? Our caseload right now is assumed to be higher than even what I projected because we're not reporting and also we're not testing as much. So I don't want to go into too much of this detail, but yeah, hopefully we'll be able to deliberate on this. And thank you so much for the opportunity to share these insights. Over.
Wow, thank you, Lorraine and Yewande. It's sobering listening to you and all the things that are happening. Thank you for highlighting that, in the longer term, of course, we need larger oxygen plants but for the shorter term, oxygen cylinders would be great. Now, I'll move on to Alice, our second speaker, and Alice is in a more rural context where they've felt the pain so much. Alice is the executive director and founder of Terrawode. Terrawode works to improve the status and livelihood of women and children with a focus on maternal and child health. So most of Alice's work focuses on rural women and girls. And Alice, we know that COVID-19 has worsened the plight of people in rural Africa, especially women and girls, as majority of the country's poor live in rural areas. So what are the health and economic impacts that you're seeing in the community where you work? And what is happening at the hospital that you run during the lockdown? And maybe you could also paint a bit of what's happening on the oxygen side there at your facility. Thank you.
Good evening, good morning in Uganda and other parts of East Africa. For our viewers, the situation seems to be very pathetic, but at the same time, it's manageable. There is a lot of resilience among the population, even the rural women and girls, people in the communities. People are positive. People are complying to the COVID-19 SOPs amidst all other limitations. I want to say that, first of all, in the first lockdown, there was a very positive response, even in the rural areas, where whenever they got the information, and there was high level of compliance. But then later, around January, February, there, fatigue set in, and people relaxed. There was relaxed, and at that time, the level of the perceived level of risk, factors was low, so people really relaxed. There were not many deaths recorded. Currently, as we are speaking during the second wave, the communities have perceived that the risks of dying and catching COVID infection is high. And so there's a lot of anxiety, there's a lot of fear, there's a lot of uncertainty even among these people, these women in the rural areas. But I won't say that they are complying. The level of compliance is high, and they remain still resilient, wanting to see that we put to the past this current COVID situation. However, there are huge challenges that come along with this lockdown and these restrictions that are associated with the lockdown. One of them is the high cost of transportation for women to go and seek for services. The high cost, most of them travel with the motorcycle, motorcycles and bicycles, but the owners of the motorcycles now are charging exorbitant fees, more than double the cost. So now for these women, these rural girls, it's so difficult. The other thing is also the accessibility and the availability of this transportation. It's not readily available because the travel times are limited and they have to get clearance from their local leaders, which is an excellent thing. And I think it's the success of all the efforts that all stakeholders in Uganda put in during the first wave of COVID-19. So these are the challenges in the health facilities, but more so I work in 3 large regions of Uganda, but more so immediate one is in the Teso sub-region, which we have closely worked with some health facilities in the communities, is that there is a drop in the number of expecting women who are attending antenatal care clinics, at least by 7%, almost 7%. There is a drop. There is a drop in the number of women who are seeking for deliveries in the health facilities because of these transportation challenges. But there are also this anxiety that associated with it. So there is a fear. There's a lot of fear. People have gotten inconsistent and incorrect messages about COVID-19. And you can trust that because by the time information gets to the lowest person in the family unit and to a woman particularly, a lot of distortion will have what? Taken place. And people are turning to whatever direction to get information about how to prevent COVID, how to, the supportive treatment for COVID if you tested positive, and then how to deal with the stigma associated with it. So it has made most of these women and communities to be relaxed in going to seek for health. And if they went, they are going in to heal for other health conditions. If they went, actually, they are going in a little late when the condition is severe. So meaning in an emergency state of affair. Now, again, you find in the health facilities, they are dealing with COVID-19 as an emergency. And then these ones are also going with asthmatic condition, pressure, malaria, labor, and they are going in an emergency situation. So this is kind of overwhelming to the health center. But there is this thing we have noticed. It was there rampant. I think you must have heard about it. Gender-based violence, particularly domestic violence among the women and the most vulnerable in this society. So now, if somebody has expressed a need to go to test for COVID-19, that's also a problem. If somebody has come, want to go to get some food or continue with doing some business in the local market because the food stores are not closed, that is bringing, those who have the power in the home state are dominating and controlling that space. Mm-hmm. And then for the ladies who are suffering from fistula, which is the condition that my organization has put in a lot of effort and dealt with for long, this is the time they're experiencing a lot of tension because this condition requires you to have soap regularly, to wash yourself, to clean pad, to do what kind of thing when you're living with it. So we are receiving lots of calls in the community, high demand for care for this service, but the challenge is the transportation. So there's domestic violence, and which is hitting them psychologically, emotionally, physically. The other one is, which others have already said, is the issue of lack of PPE. Even in rural areas where there are, we've trained some people, other stakeholders have tried to support them, and they are trying to create PPE, the face mask for themselves. But the quality of the face mask they're using in the rural areas cannot help with this situation, cannot prevent them. And so it's so challenging for them. But the good thing is that if they've gotten the message of staying at home, social distance, they would be able to probably contain the thing. The other
Alice, I'm going to jump in.
I think I took it.
Just in briefly in 1 minute, how can we help your community? The issues seem overwhelming, and we would want to know, how can we support you?
So first of all, we have a hospital, a dedicated women's hospital, which is providing routine care of obstetric fistula holistically, including reintegrating these women. This hospital is functional. It's the only one that is currently operating in Uganda. And I think how you can help us is to help us continue to provide these services, but while ensuring that the ladies are not exposed to the risk of getting infection. And so having a rapid test kits, which we have integrated into our facility. The test kits are not available, training the community volunteers who are in contact with these ladies in their communities as trainers or trainees, so that they can pass out, they can deliver consistent and accurate messages about COVID-19, supporting us to engage with the local media in local languages, in the languages that the women can listen to. I think this would be helpful to support us. We want to train. We've been training some of them to produce, for example, the liquid soap. We have some survivors in the community that can produce this. They need support, some emergency fund to support them to restart or to continue with their small businesses so that they can support others, because we train this as advocates. So we have advocates in the community. We need support to be able to empower them, to reach out to them and provide them with the accurate information. But also we need to, like in the hospital, we have an isolation unit within the ward, but now we need to create additional spaces in the facility. We need to create spaces like an isolation room for COVID patients so that it is not within the isolation room, which is in a routine hospital. Equip it, and so that when the ladies, an emergency of a COVID suspect, surfaces, they are quickly removed and taken to that ward before we do connections with the other health facilities. So we want scale up the counseling and psychosocial support services in all the regions of our operation, because there is a way this COVID is impacting on the lives of people in all areas. And then continue to operate. We have a health line, toll-free hotline, which these communities reach us on, but we need to continue to engage them, not only through those online platforms, but holding small community level meetings, supporting those community orphan, and also engaging. We've been engaging with the task force. We want to continue to engage with them at a higher level so that maternal health is not ignored during this time. I know we can do it.
Thank you, Alice.
We have to be hopeful.
We are so grateful to the work that you continue to do. We know you are doing a lot, and we are so grateful. We hope that you can find all the support that you need to continue supporting these women and girls. So I'll move on to our next speaker, who is Dr. Pasquin Ogunsanya. She's a medical doctor and a public health specialist. Dr. Pasquin is the executive director of Alive Medical Services, and it's an organization that provides free, comprehensive HIV care to some of the most vulnerable individuals in one of Uganda's most densely populated and impoverished neighborhoods. So Dr. Pasquin, you work mostly with the urban poor and people living with HIV, majority of whom actually live hand to mouth. So with the lockdowns reinstated, these people are being asked to make a very difficult choice between being hungry or risk getting infected by COVID-19. What are some of the health and economic impacts that you're seeing with the urban poor? And how has the COVID-19 pandemic impacted the continuum of care in HIV? Should we be concerned that the gains that have been made in HIV prevention and testing are being reversed? Over to you, Dr. Pasquin.
Thank you very much, Evelyn, and hello, everyone. Thank you for having me on this panel. Yes, the question you've asked is really a worry. We know that Uganda had made a lot of huge strides in reducing HIV and its burden to the population from 2010 to 2018, but COVID-19 has caused serious damage to these gains. And this disproportionately affects the most vulnerable and marginalized populations and the urban poor whom we serve, and especially girls and women. Girls and women have been the face of HIV. So HIV is not over yet. A recent study from WHO and UNAIDS concluded that interruptions in ARVs for 6 months will cause HIV-related death to rise by more than 500,000 in sub-Saharan Africa, and also mother-to-child transmission to double. And HIV testing, that is a linchpin between prevention, care, and treatment, is also reduced, so HIV incidence would rise. And like my colleague said earlier, there's now a lot of gender-based violence, there's a lot of teenage pregnancy, and that's where the women get infected again. So the urban poor whom AMS serves, they move from the villages to town to look for odd jobs, and they live from hand to mouth. And of course, the prevalence of HIV is highest among, in the urban area, and especially Kampala, where the prevalence is around 7%, but among marginalized populations is about 13%. So when COVID became a pandemic, travels were restricted, physical distancing, curfew, and fear, and this has really affected treatment and essential health services, just like Alice mentioned. The urban poor lost their jobs, businesses, and they have really gone to deeper poverty. There's a lot of fear, there's a lot of anxiety, there's a lot of desperation, and there's a lot of poverty. So these are some of the voices of the people living with HIV that we serve. And just to mention that every year we serve around 134,000 people, and 17,000 of them HIV positive. So we have a very high volume of really poor people accessing our services, because all our services are free of charge. It's comprehensive. It's like a one-stop medical center. So these are some of the voices. One of them called and said, I'm trying, but it's not easy. I was meant to come to the clinic on Tuesday, but I was refused by the police. It was difficult for me to explain why I'm going, because they were just beating us. Another one said, the situation is very bad. I'm having 1 meal a day. I have my ARVs, but I'm fearing to take it because it's strong and I have no food. So what are the needs of the urban poor who are living with HIV? Like Alice had said, transport. It's very difficult for them now to travel to the clinic to get their medication. And they need their medicines. They need delivery of HIV prevention services at home. Things like condoms, risk reduction counseling, sexually transmitted infection testing and treatment, pre-exposure prophylaxis, post-exposure prophylaxis. These are ARVs that are given to prevent when they are exposed or to prevent them from getting exposed. And also information on HIV, sexually transmitted infection, COVID-19, and other materials. They also need provision of COVID-19 infection prevention supplies like masks, sanitizers. They also need HIV testing services like self-testing kits and also STI testing kits. They also need their ARVs delivered at home, because now they cannot come to the clinic. There's a lot of mental health issues among HIV positive clients, and they need psychosocial support. Most of them don't have food. They need food. They need mental health support. They need intensive adherence counseling, because some of them are so desperate that they are not taking their medicines. They need airtime maybe for communication. They need a lot of things. Some of them have lost housing. They need protection from gender-based violence and abuse. Some of them need space where they are safe. And the children are at home from school, so they are being exposed. There's a lot of teenage pregnancy. So what innovations did AMS do? AMS did mapping of where people living with HIV live, calling them on a daily basis. Those who are on appointment, we organize and deliver their ARVs at home using peers, using bicycles, using motorcycles, using community health workers, using the health workers themselves. And we've also had our health workers sleeping at the hospital, at the clinic, so because those who are living far, so that when the clients come, we are able to deliver their medicines. We are also using courier to deliver these medicines. We are using actually trucks that are going, that can deliver cargo to deliver these medicines. And clients who are not very far, of course, can walk to the clinic. So we've also been looking for funding and resources to enable us do that, because we are delivering all these services at home, prevention services, testing services, treatment services, and virtual delivery of psychosocial supports. We are calling them, all our clients, we call them on a daily basis. So we have a team calling them because they are very stressed and worried that they may not have their medicine. Those who have cannot take. We are also using local radio to sensitize on HIV and COVID-19. And we have also been giving nutrition support to our clients. One of the things that we did with some of our partners, we actually have a strong partnership that is supporting us. We have partners from Australia, since 2010, we've been partnering with great partners in Australia like Pink Umbrella Foundation, Rotary Club of Woy Woy, DAC Foundation, Rotary Australia World Community Services, and Partners for Equity. So our funds from Australia actually sent through Partners for Equity. And with these partners, strong partners in Australia, we've been able to provide all these services. We also have partners in the US like Keep a Child Alive, which is Alicia Keys Foundation, Procter & Gamble. We also partner with the CDC, which is the US government. We also partner with Frontline AIDS in the UK, and we also partner with the Ministry of Health. So with our partnership with the DAC
Dr.
Foundation.
Pasquin, yeah, just to wrap up that partnership with DAC, I'll give you less than a minute. Thank you.
Yes. So anyway, we've been able to do cash transfers to over 2,000 clients. And this happened for 4 months. And we really saw the impact of that because we have mobile money services in Uganda that work very well. So what is our need as Alive Medical Services? The immediate need is to ensure uninterrupted care and treatment for vulnerable people living with HIV and the poor, and to prevent death among people living with HIV due to HIV-associated comorbidities. So we need support, we need partners who can help support us to fund this so that these services continue. We also need to have infection prevention treatment and infection prevention supplies like masks, sanitizers. And so we need partners who can support us with this. We also need human resource to be supported so that we can be able to support all our clients in the different areas.
Great. Thank you, Dr. Pasquin. Thank you so much. And so good to see the comprehensive services that you're providing with your clients. And hopefully we will have more support through our Australian network to help get this work continuing to move. So our next speaker is Charlotte Oloya, and Charlotte is the Country Director of School for Life Uganda. School for Life operates 3 schools in rural Uganda, providing quality education, healthcare services, and community uplift programs. So Charlotte, COVID-19, of course, is endangering the gains made with education across Africa. And some students in Uganda have been out of school since March last year, and some might never return because they either became pregnant or were married off. So what impacts are you seeing in the field of education? And this is broadly. So what's happening to the learners? What's happening to the teachers? What's happening to the schools? And what are the top priorities to address in the education sector, and what do you need? What support do you need? Thank you, Charlotte, over to you.
Thank you very much, Evelyn. As you quite rightly put it, education institutions have been closed down since March 2020, to be precise, 20th of March 2020. And since then, the government of Uganda, to their credit, did try to reopen schools, and they did it in a staggered approach, starting with the candidate classes and allowing them to sit for the national exams. We had primary 7 and senior 6 and senior 4 sit for their national exams. Unfortunately, as we're having more classes report to school, we had the 2nd or 3rd wave of COVID, as our colleagues from CHAI have pointed out, and the government has had to close down the schools again. We're seeing that there are over 15 million children across the country that have been affected by the closure of schools. Like you so rightly put it, these children, many of whom will not return to school because they've either become pregnant or have had to change, are tired of just staying at home and not wanting to return to school. Because of the closure of schools and the staggered approach to the reopening of schools, ECD centers actually since March 2020 have not opened at all. And we're aware that ECD centers provide more than just formal education. They also provide an opportunity for women who are the most vulnerable people in our community to be able to work because they are young children, because they're the main caregivers. They can go into the market, they can go to work, but because ECD centers have been closed, it's been a challenge for the women to earn a living. But also most ECD centers in the country are actually owned by women. And so we see an impact on the income of the women who would run and own those ECD centers. we are also seeing that, the government did, in the initial lockdown, did promise, that radios would be provided to the population, particularly those in the rural areas. But this is a promise that is yet to be delivered on. The government did put learning materials in the newspapers, but many people cannot actually afford the cost of having buying a newspaper in Uganda, especially in the rural areas. So we're seeing that the impact of COVID-19 on the education institutions, particularly on our children, is that we have about 2,300. UNICEF reports that about 2,378 children have been vulnerable to teenage pregnancies, and this was just at the end of 2020. So we're yet to see the impact in 2021. There's also issues of early childhood marriage, and as my colleagues have rightly pointed out, gender-based violence, even to the children. Many of these children who have been prone to these challenges did not return to school with the staggered approach, and these are just the top classes. We didn't actually see the lower classes, ECD, primary 1 and primary 2, return to school. With the increasing number of COVID-19 cases, we've also seen that many caregivers have become sick. The report from the government from the 28th of June states that, notes that there have been about over 70,000 cases of those who are sick. It's not disaggregated, but many of those are caregivers to children. And what that means is that our children then are left distressed and vulnerable, having to fend for themselves. Many have had to, due to too many domestic activities, or have been pushed into hazardous work, for example, working in quarries or in markets, or have been pushed into exploitative situations to support their families. With the rising numbers of deaths, by the 28th of June, the government was reporting about 900 people who had died to COVID. Of course, these are just reported cases. It may actually be more numbers on ground that we would know of. We are seeing that many of our children are being left orphaned. Their guardians are passing on, and what that means is when school actually resumes, these children will not be able to afford to come back to school, will not be able to afford to get out of poverty using education. And also with the persistent lockdowns and the fact that businesses are closed and there's no access to many businesses, parents are losing their sources of income. And so when the government says purchase a newspaper, or charge we're going to use television, which when we don't have electricity, and then there's reduced income, parents have lost their jobs. It means that many of our children also are then left vulnerable, and then we see the girls pushed into issues of transactional sex, in order to buy pads, in order to access access things that they need in order to continue to live within the community. Of course, the teachers have been affected. Many schools have been closed, and these are mainly low-cost private schools. It's both affecting both the children and the teachers, because the teachers then lose a source of income and are then pushed into other businesses, which could include, being border riders. And that means there's a drain from the teaching force for the country. But also for the children, it means that if schools are closed, there's a lack of continuity of education in the schools that they were in. These low-cost private schools that are closing were actually providing a good education for migrant workers who mainly come into the urban centers. And so with this closed, that means that education for those migrant workers' children is also affected.
Charlotte, very briefly, how can we support you? I'm conscious of time here, so that's why I'm moving to that point. Yeah.
Yes. So because we recognize that we need to use education to drive, we don't want to lose the gains that we've made and to minimize the disruptions to education. Our top priorities at School for Life are one, to ensure that our children have a quality education even while at home. And so we even during the first lockdown, we continue to provide home-based study packages to our children. Our teachers have also continued to call the children our community team is also calling the children to ensure that they're providing counseling to those who are getting distressed by the fact that schools are not opening and they're not being promoted to the next class, but also for the teachers in order to check that the children are learning, not just that they're getting work, but they are learning and introducing new subjects and new topics to them. We are also catering for the vulnerable population. We are pivoting education. And right now we're very excited that in our rural area communities that we are partnering with, we are introducing Google classes to our children. We are providing Android devices for the vulnerable populations that cannot access them. We are also working on providing COVID scholarships to children who have been affected by COVID, whether it's, but if it's children who've lost their parents or their guardians, but all children who have lost income, parents who have lost income. We are continuing to build the capabilities of our teaching staff. We're not leaving our teachers behind and continuing to keep them engaged during the lockdown. We're ensuring, as the previous speaker noted, we're ensuring that our communities get the right, correct information about COVID-19 to minimize spread with the community in the communities with which we partner with. And we're also continuing to partner with other NGOs and the ministries and health centers that are around our communities to ensure that people know about vaccination, when they can get it, what it does, and just debunk certain myths around this. Of course, we always need people to partner with us, especially as we pivot into strengthening the ICT infrastructure in the rural areas. And we're very open to other, to people, anybody who would like to partner with us to push the extension of the ICT infrastructure in the rural areas, providing tablets to our parents, to our communities, ensuring that there's continued psychosocial support for our communities, and just skilling our teachers and our learners. Yeah, thank you very much.
Charlotte. Thank you, Charlotte. Wow, there is a lot happening here, and a lot has been shared on the situation in Uganda. It's mostly devastating, but also we have seen that there are a lot more opportunities for us all to think hard about, how we can support, what ways we can help, and in what ways we can respond. So I would love to encourage all of you to think about how you can plug in and how you can help with the situation in Uganda. So just to reiterate, feel free to use the Q&A and chat functions to send your questions. I see a number of questions already coming in, so thank you for those. We'll get to them in a moment. So let's hear from some strong partners here in Australia on what they're doing. And just before we go to Madeline from Adara, I would like to highlight the work of FREO2 Foundation Australia. We've not been able to have a panelist on here today, but just to share that last year, FREO2 Foundation Australia supplied 13 oxygen concentrators, pulse oximeters, infrared thermometers, oxygen analyzers, and nasal cannulas to the Ministry of Health in Uganda. And this donated equipment was deployed in COVID-19 centers across the country, in high dependency units and intensive care units. So thanks to FREO2 for doing that work and for supporting Uganda already. So right now, I would love us to hear from Madeline from Adara, and she is the Chief Executive Officer of Adara Development, an international development organization with expertise in maternal, newborn, and child health and remote community development. So Madi, what is Adara doing in Uganda, and how have you adapted to fill the gap?
Thank you so much, Eve, and thank you for that shout out for FREO2 as well. We're very excited that we're going to be partnering with them on some newborn work later this year. So like many people on this panel, our experience at Adara and for our team on the ground has been very similar challenges that we've faced. And a lot of these challenges have not been just from COVID, but also from the effects of the lockdown and the restrictions that puts in place. So the issues around transportation, the issues around access to medical care have been really exacerbated by the public health measures that the government has had to put in place. I think Adara works across 3 districts in central Uganda in both facility-based care and also community-based care. And one of the things that we're observing is very high risk to healthcare workers at the moment. So at our main partner hospital, Terrawode Hospital, already 46 of the staff have contracted COVID. And across Uganda, there's over 2,500 healthcare workers who have contracted COVID in the past month. I was so devastated yesterday to read in the paper that 15 doctors have died from COVID in the past month, including 10 pediatricians. And as we all know, the Uganda cannot afford to lose these amazing people who are on the front line of this crisis. So I think a huge focus for us and for, I'm sure, all of us on this call is really around how do we protect those on the front line, as well as they are being so incredibly brave and stepping forward to care for people who are very ill with COVID at the moment. So Chiwoko and our other partners that we work with are facing very similar challenges with access to oxygen, with access to PPE being a big issue, access to testing, all of the things that we've heard about. And Adara has been trying to plug these gaps as best we can, but more support is needed. So anyone who has capacity to support in these areas, I would really encourage you. I think the other area that we've been really focused on is these secondary impacts. And so Adara's expertise, as you mentioned, is really in maternal and newborn health, particularly small and sick newborns. So little preterm babies is kind of our area of expertise. And our partner Chiwoko Hospital has a Centre of Excellence in newborn health and an incredible neonatal intensive care unit. And what we're seeing is, like Dr. Pasquin mentioned with HIV/AIDS, we're losing the gains that have been made in newborn health. So Uganda's been seeing some really impressive reductions in newborn mortality, and we're seeing this go backwards with this crisis. So Adara has a very detailed database at the hospital that we work in, collect very rich data at the NICU, and we've seen really dramatic reductions in survival for babies, particularly born outside the hospital. They're getting there later or they're not coming at all. Rates of birth asphyxia are a lot higher because women are not able to get to the facility in time for a safe birth. And I think it was very shocking for us when we did that analysis to see a relative increase of about 55% above the seasonal expected mortality for babies born, outborn patients admitted to neonatal intensive care. And this is one unit in the country. So I think a big focus going forward also has to be, how do we build back after this crisis, and how do we regain all of the steps that were made around maternal and newborn survival that have been lost during this crisis. We need to focus on that now during the crisis, improving access to transport, improving access to education. There is so much fear and anxiety about coming to a facility because of the risk of COVID, but I think it needs a very deliberate focus as well of, after we get through this crisis, how do we build back better and regain all the steps that were made across so many areas of health and education, as the panel have mentioned today. So I'll leave it there unless there's any other questions, but thanks, Eve.
Oh, thank you, Maddie. And thank you so much to all our speakers today, to all our panelists. You're all doing very, very amazing work. And we know that with partners as strong as you on ground, we shall see some progress in some of these areas. So thank you so much. We'll now move into the Q&A, but just before I do that, I think I just saw something posted here that DAC Foundation and PFE will be sending through emergency funding of $25,000 to Alive Medical Services for their work in HIV in Uganda. Thank you so much, DAC. That is amazing. So with the questions that are coming in, I see some of them have actually been responded to in the chat. So thanks for that. I think the first question was from Caroline. Can you expand on the strategy for vaccination? I think that has been answered, correct? Yeah, I think it's been answered in the chat. So thank you for that answer. And the second question is from Joseph. And Joseph is asking, wearing masks is one of the best effective methods to protect against COVID transmission. This is relatively low tech. What is the status of access to masks and uptake to wear masks while around people in public? I can assign that maybe. Yohan, did you want to take that? Or any of the other panelists can jump in to answer Joseph's question. So Joseph is asking, what is the status of access to masks and uptake to wear masks while around people in public?
So maybe I can share a few thoughts as other panelists share. Based on what we've seen, at least in the initial wave of the pandemic, government opened up the manufacturing of masks to the private sector. And I think that had a significant role in just creating a healthy market for the public to access masks from in country. And there were guidelines on how those masks should be manufactured. And so right now, you can get a mask for less than $1. Now the question, I guess, is compliance. We've seen better compliance during the resurgence, so better uptake and utilization during the resurgence. So it's almost like people are now afraid, of catching the virus. And so they now see that they need to wear masks more than what we saw in the first wave. But I see Dr. Paskin's hand is up, so maybe she can also supplement. Over.
Yeah, briefly, Dr. Paskin, you want to jump in?
Yes, thank you very much, Evelyn and Lorraine. I think I also concur with Lorraine that initially there was laxity, but now people are so afraid that they can use masks. And we've seen, for example, at Alive Medical Services, you cannot enter without a mask. And once people understand that, they will wear a mask all the time. So people are beginning to really take, there was fatigue, and of course, some people were desperate, so they didn't care, but people are now beginning to use masks more. Thank you.
Thank you, Dr. Paskin. Another question from Kaushi: are all referral hospitals in need of oxygen? Probably.
Yes.
Yes.
Yes, thank you for that question. Yes, all referral hospitals are in desperate need of oxygen. As I had mentioned, the supply that we're able to get from the on-site plants, the demand exceeds that supply massively. So that's why we brought on board these private suppliers, which are helping for the current situation. However, as we get more and more cases, we'll eventually also exceed that supply as well. So that's why we're planning now to build the capacity and get these larger plants in.
Oh, great, thank you. We'll take one last question and wrap up. Manny Rickards is asking, are there still some oxygen plants at referral hospitals with insufficient power?
Yes, so this was one of the major challenges that we were facing initially, because of course power is needed to keep the plants running, and there were a few sites that really did not have stable power. So they were really unable to produce much oxygen from these plants at all. However, what we've been able to do during this surge, we've been able to partner with UMEME, which is the Ugandan national power supplier, to provide separate lines for these regional referral hospitals and stabilize the power supply, particularly during this time when we're really needing these plants to be in operation fully. So we've worked with UMEME to stabilize the power in some of these sites. We're also getting generators in to try to have a backup system, but we need more. Over.
Thank you, Yewande. Unfortunately, I'm going to have to wrap up now. There's still a few unanswered questions, but feel free to email any of us or AIDN. We can answer those questions for you. So thank you everyone again for participating in today's webinar. There's a lot to take away from here. And again, I would like to encourage all of us to think hard about how we can support, how we can help Uganda and the organizations, the amazing organizations that we've had from today in today's webinar. Thank you so much. And over to you, Julie.
I'm just going to wrap up very quickly. The fear and anxiety is palpable, and I want to thank you all for being on the panel and actually sharing what's going on. I want to thank everybody in the AIDN audience for listening in, and we for sure will be thinking long and hard about what we can do to help. It's inspiring to see the collaborations with DAC and PFE and Adara, and maybe this will be one thing that comes out of COVID where everybody tries to join as much closely together and to work together to have the biggest impact. You'll get a recording of the webinar in a couple of days together with links. Please respond if you've got any suggestions and thoughts, and we'll be back in touch. Thank you all again. It was amazing.